and maybe save money, because you can bring him back at another visit in a month and see how well he improves with some physical therapy and not go to the MRI or not go to things, because then you're thinking an operation, which I'm not convinced he needs. So personally, I would think that the scapular dyskinesis is the major problem, and I would work on that.
Okay. I agree with that.
And I think the issue that comes up that Pat was kind of hitting on is whether you feel that the scapular dyskinesis is a primary problem or a secondary problem, because you'll see it in both situations. You'll either have the scapula not working primarily causing the problem, or the scapula not working secondarily to a problem within the glenohumeral joint. And in this situation, based on the history, without a specific traumatic event, I would lean towards what Pat was indicating, which is that the primary problem is the scapula. Deal with that first from a rehab perspective, and then if you don't see the improvement that you would expect, then I would probably pursue a further diagnostic intervention.
Yeah. That flow chart that I showed, the exam is to determine where you are on that flow chart, and I think his primary problem is his scapula. The one thing I didn't do with him that we still have to do is show me how you can reproduce your pain. Yeah, because he was able to show it to me yesterday when we accepted him as a candidate. So.
The pain doesn't really happen until I go past this area. When I go up and I go past it, there's like a little area in there where I feel like it clicks when I get past it. So up here I'm fine. Maybe the click is something. Once I start to back down, here it starts to get rough, and then it starts to have that pinching sensation I was telling you about, and then it clicks past it when I get lower.
Okay, so let me get you to stand up. I just want to try something with you. I'm facing that way, if you would.
But based on what he just said, I would think, again, it's going to be probably more a dynamic problem than a static problem. And I would really want to see what you could do as far as dynamic strengthening and stabilizing the scapula to see if this can go away. Because obviously, that's the preference as opposed to a surgical option.
Yeah, I agree. I was actually expecting from the history that I got from him outside yesterday that he would have a painful arc. From the history, I thought that would be the case, and that therefore we could change it with the scapular assistance test. So he's describing a painful arc, but he couldn't show it to me. So let's see if, now what you just did that could you feel the discomfort when you got up there?
Kind of. It can get a lot worse than it is right now, but
okay.
I could feel it.
Okay, so let's see if we can change that by doing a little scapular assistance. So bring your arm up and overhead. Does that change it? Okay, bring it down. And let's bring your arm, swing it forward, and let's do that. Let me get, just one sec. Here you go. Okay, and now bring it forward. Any change? Okay. So different, but hard to tell if it's improved. Was it? Okay, I couldn't see that in the front. So, I mean, if the diagnosis, I don't know that if his labral click has any significance at this point. I'm not ready to buy in for an MR arthrogram for that, because that to me is a preoperative test. I agree completely. So I think you've summarized it very well. That, to me, this is the first visit. I've identified it as a scapular dyskinesis problem. I would probably do the same thing and have my PA go through the program with him, and then I would pick my physical therapist very carefully, because most of the stuff that I've shown, I don't necessarily do on the exam. I do enough so that I know whether it's a structural problem or a functional problem, and then send the patient to the right therapist and say, correct this. But for the diagnosis that you're going to give the therapist when you on the slip is scapular dyskinesis. And I would hope that they're then going to look at the shoulder in the context of the kinetic chain for me.
Ben, we have two portable mics here, so
okay.
If the audience has any questions at this stage, put your hand up, I'll get you the mic, and you can address those either to the patient or to Ben, or the panel. Anybody have any questions?
Mark, do you have any, while we're waiting for questions, do you have any thoughts about what you would do differently as far as your exam? Because you can actually start thinking about, actually you can start working into, before the break, how you would approach him. If we don't have any questions, then we'll have Mark get started.
Hi, I'm Gino Del Maggiore from San Jose, California. When we're talking about MRI and exam, young kid, and the issues we've talked about, where does an x-ray fit into someone who's young like this? Does everyone who walks in the door get an x-ray or not?
If I think if with this history, I probably wouldn't get an X-ray. In a 24-year-old healthy guy with no specific trauma, the one qualifier is I would want to get a feel for, since he was involved with breakdancing and can't recall a specific historical event, he may have had some trauma to his shoulder, but I don't think it would be bony. So I don't think I'm going to see anything, so probably not. Unless my office staff in our quest for efficiency would have ordered it and had it done before I went into the room. But usually not.
Thank you.
Hey, Ben, the only thing that I've learned the past year is I asked the patient, can you make your shoulder slip or make noise or go out? And because every now and then I've had a patient who can voluntarily sublux their shoulder and posteriorly, and I'll go through all these maneuvers, and I can't elicit anything other than a little bit of pain. So I've just added that to my repertoire. Can you make it, do things funny or not?
Jack Ebert, Kaiser San Diego. Patients often come to us with complaints of crepitation, and I was just wondering if do you classify your crepitation in any particular manner, and then what significance do you place on that?
I don't classify it. My thought is it coming from the subacromial, whatever that noise, whether it's crepitus or grinding, is it coming from the subacromial space or is it coming from the joint? It's either intra or extra articular for me, and what do I have to do, or does the patient have to do to reproduce it? If it's not painful, I'm usually not concerned, especially if it's in the subacromial space. If it's a click or a grind that I think is intra-articular, then I'm more concerned. I went through a period where I thought that, it was almost 20 years ago when I spoke here and talked about physical exam, and I was getting into auscultation of the shoulder, and I was actually taking a stethoscope and listening to shoulders to see if I could identify where the noise was coming from, and it wasn't helpful. So, but I did say that at future meetings, so the people who were asking me, are you still doing it?
I think that's a great question because that's what the patients come in and ask about. They say, well, my shoulder's popping, and they think that that's pathological, and oftentimes it's not. I'm very lucky in that my right shoulder has painless crepitus, so I can have the patient put their hand on my shoulder. Mine crunches always worse than theirs, so then they're reassured. But Ben also talked about differentiating subacromial space versus the glenohumeral joint, and I think that's important because a lot of it is just a little bit of bursitis, and they've got some thickening of the bursa, and that's what that's coming from. I think there's a big misconception as far as rotator cuff syndrome or impingement syndrome, and especially in a patient like this. The acromion is not the offending structure. The acromion is static, and it's because the head is coming up that the problem is. So it's a dynamic problem, and I wouldn't get an X-ray the first visit. I'd get it on the second visit if he had gone to a good therapist and he was no better and it was still going on. That's when I'm going to put my diagnostic mode on and try to figure out why this is not getting better. But the crepitus itself isn't usually, we see so much of it and it's not really a problem. Even after they get better, he may still have crepitus. So.
The other area where you see a click commonly is the AC joint, and that's one that you can put your fingers on and usually reproduce it. But I think that the key is whether the noise that they're appreciating or hearing is really associated with the symptoms that they're having.
Yeah.
Ben or panel, in terms of the role of your diagnostic injections, granted maybe on a young guy you wouldn't consider that, but when you're talking about X-ray, MRI, in the process of your exam, a diagnostic injection could be pretty helpful. Would you kind of comment on when you use those and why and it could just be, Marcaine or xylocaine or something, intra-articular versus subacromial?
Yeah. Do you want to go first, Nick, and then we'll work?
Yeah, I don't use injection so much in the labral setting. I use more of a clinical history and exam. I use an injection primarily in two situations. Number one is AC joint pathology. I think it's a readily accessible area. It helps to define the AC joint as a source of pain and to isolate the AC joint as a source of pain. And most recently, I've been using injection frequently for biceps-related symptoms, for the anterior shoulder pain in the diagnostic setting. And I use an ultrasound-guided injection just so I can be confident that I know where I'm placing the injection.
I use it primarily in the AC joint and subacromial space. I think it's very, very helpful there. But for the patient, they would have to have painful crepitus. I'd have to be convinced that it's in the subacromial space or the AC joint, but you can usually determine that by palpation and some of the provocative tests. And I think that it's very helpful. I think the intra-articular injections, especially now that there's more and more talk about the toxicity of local anesthetic, I think we're going to have to start staying away from that because the lawyers are right behind.
I agree with that. The only time I inject intra-articularly is if I think it's early stage adhesive capsulitis in the inflammatory phase, and I think I can impact the patient and get a feel for what stage they're in. I don't use. I used to use it when I was over with the residents at UCI in the clinic, and I had somebody with scapular dyskinesis, and I thought that the primary problem was the inflammation in the subacromial space that was kicking back and shutting down serratus anterior and lower trap. And I would inject local anesthetic into the subacromial space to see if I could correct their scapular kinematics. And very frequently you can. So I think that helps you decide where is it coming from. But I don't use a lot of injections in young people, except in AC joint and bicipital groove. And I don't have ultrasound in the office, and then I'd only see 2 patients a day if I did. So we're right on time. So why don't we take a break now? We'll come back, and then Mark will tell you what he would do differently and how he'd set the patient up for a program.